I'm really pleased and honored to be here in front of the group and want to thank the organizers for inviting me. We're going to be talking about lower respiratory tract infections and a few tips from the antimicrobial stewardship aspect of things. So I've got a pretty ambitious agenda for you this morning, and so I'm going to be going along at a pretty quick clip. But by the end of my presentation, I'm hoping that you're going to feel more comfortable in evaluating and taking care of people with lower respiratory tract infections, and to be able to identify a few tools and tips that you can use in the treatment of these folks, and then really outline some antimicrobial stewardship efforts in management of lower respiratory tract infections. I have been lucky enough to work with a number of sponsors over the years. Those are on my slide here on potential conflicts of interest. My goal is to give you a very non-biased sort of presentation, and if you do detect some sort of industrial taint to my presentation, I want you to point that out to me, so make sure you fill out your evaluations appropriately. Now, we had two talks thus far this morning that were terrific in outlining kind of a broad overview of antimicrobial stewardship and antibiotic resistance at the national level and then at the state level. And the next series of talks are really going to now get into the weeds and talk about what we do in the trenches of taking care of patients with infections and how to bring some of these concepts of antimicrobial stewardship into play. So as Dr. Srinivasan said in his presentation, respiratory tract infections are hugely important in this. That easily 30 or 40% of antimicrobial prescriptions are directed towards the treatment of lower respiratory and upper respiratory tract infections. Now on this slide you can see that the respiratory tract can be conveniently divided into upper respiratory areas. This would include the sinuses, the larynx, the pharynx. Some people would throw the middle ear into this. Those are exceptionally common infections. You can see that there's about 17 billion of these per year throughout the world. And when I saw that figure initially, I was like, well, that sounds crazy. But when you think about it, there's probably about 7 or 8 billion of us who are walking around on the face of the earth, and all of us get 2 or 3 colds per year, so this is probably an underestimate. So, again, a huge burden of disease. But what I would point out to you is that easily 90% or more of these are viral, and there is absolutely just no role of use of antibiotics in the treatment of the vast majority of these infections. And that's all I'm going to say about that. If you want some additional information on how to address these patients, how to try to prevent the antimicrobial use inappropriately in that group of patients, I would turn you to a number of websites, including the one that we have at the Nebraska ASAP, the Antimicrobial Stewardship Program, making it even more important for you to fill these things out that Dr. Ashroff pointed out. And so then you can get on the list, and this will just be updated, and you'll get notification and can easily find this site. So moving into the lower respiratory tract, which includes the trachea and the bronchial passages and then the lungs themselves, there's somewhere in the neighborhood of tens of millions of these infections. It's one of the major causes of death throughout the world and is just a huge clinical importance for us. And on this slide, you can see that there are certain areas of the world that clearly have a much greater burden of disease than, luckily, us in more developed areas of the world. So the first of these infections that we want to talk about is acute bronchitis. This is exceptionally common. It's inflammation of the bronchial passages. There's about 3 million of these cases per year in the United States. The etiology is usually viral. And so for folks who have acute bronchitis, typically you would want to shy away from antimicrobial use. And the symptoms of these are documented in the slide, where people have cough. It's usually productive of purulent sputum, often discolored in its appearance. And so this makes patients worried that they've got some sort of a bacterial infection. And it's a major cause for folks to come into the office and to ask for an antibiotic prescription. Occasionally, the sputum can be blood tinged. You do sometimes have some other non-pulmonary type of symptoms, so people are oftentimes fatigued, they have some malaise, once in a while they'll be running some fevers, they do have some chest discomfort. And then one of the tips that I would point out to you is that these oftentimes follow some sort of an obvious viral infection. So they have an upper respiratory infection, and then it kind of gets down to the bronchial passages, and that's when they come in to seek care. The diagnosis is a little bit tricky sometimes, and anytime that you have a question of whether this involves the lung structures themselves, I would advise you to get a chest x-ray. The course of this is self-limited, but again, something that I think you should tell your patients is that this can last for weeks. That people can have this nagging cough. It can go on for 2, 3, 4 weeks. They oftentimes have kind of a reactive airways with this, and to not get overly excited about it. The treatment is supportive. You don't want to give antibiotics for this, and then obviously preventing this is important with trying to quit smoking and giving people appropriate vaccinations. Now, a little bit thornier problem that we face in clinical medicine is what do we do with these folks who have chronic obstructive pulmonary disease or emphysema and the exacerbations of those conditions. This has been understudied for decades, and I don't think we still have the answer for it. But there is increasing amounts of information. And so the questions that are often asked is, should patients be on chronic antibiotics to try to prevent these frequent exacerbations of bronchitis? Some of the older studies suggested that that wasn't very helpful, and frankly, when looking at the compilation of data now in large databases and doing meta-analysis on it, there probably is some benefit for some groups of patients to be on suppressive antimicrobial therapy. And so the two approaches to this are generally giving somebody azithromycin 3 times per week or giving people other macrolides on a daily basis. Now, the data suggests that you prevent about 30% of the exacerbations of the bronchitis, but it comes at a very, very high cost. And I think that if you look at this from a more of a societal point of view, it's probably not worth it. And so even though you are preventing some of these infections, the data has not been looked at for any longer than a year, and it comes at a cost of antibiotic resistance, QTC prolongation, and probably killing a few folks unnecessarily, and then also hearing problems, et cetera. Also, there's no impact on hospitalizations, there's no impact on mortality, and so again, I think that I would suggest that the impact of this is just not worth the price, and therefore I would suggest that you shy away from this. The other question that we frequently get asked is, when should antibiotics be used in the treatment of acute exacerbations of the chronic problem? And again, this is something that we've been looking at for a long time. We don't have all the answers to this, but the more we look at it, the more we realize that viruses oftentimes are the triggers for these exacerbations, and obviously antibiotics don't have a great role in that. This old rule of thumb of patients that you want to use antibiotics in, I think, is helpful, and therefore you want to look at your patient, and if they have increased purulence and volume of their sputum and they're short of breath, that is a subsegment of patients who are having an exacerbation that you want to consider antibiotic use. And then what has come along more recently is the use of procalcitonin in that group of patients. So if they don't have all 3 of those symptoms, I wouldn't even bother getting a procalcitonin. I would just tell them that, this is probably virus and you probably aren't going to benefit from antibiotics. But if they do have all 3 of these symptoms, then I think you go ahead and you get a procalcitonin. And if it's less than about 0.25, you suggest to the patient that the use of antibiotics is not going to be very helpful for them. If they do meet these criteria where they do have an elevated procalcitonin and they do have increase in their symptomatology, then you go ahead and put them on a course of antibiotics. I would suggest that doxycycline, maybe cefuroxime or amoxicillin clavulanate would be your drugs of choice. In our area, we have such high resistance of pneumococcus to macrolides, I would shy away from the prototypical Z-Pak. And I wish I had been the marketer who thought of that, because that was brilliant. Z-Pak is just amazing. And I would again suggest, for some of the reasons that were pointed out by our previous speakers, that fluoroquinolones is probably overly broad and associated with way too many serious side effects. And so again, I would stick with these other simpler antibiotic approaches. Okay, so now moving into pneumonia. And it was suggested to me by the organizers that a lot of folks in the audience really don't see patients at the bedside so much. And so I should concentrate on talking a little bit about the real clinical evaluation of these patients. So that's what we're going to do. Again, just to emphasize the importance of lower respiratory tract infections, in particular pneumonia. There's about 1 million hospitalizations in the United States with these infections, 8th leading cause of death in the United States, $10 billion spent. So the impact is fairly obvious. Now, one of the things with pneumonia is that because they are such a frequent cause of death, there's a huge worry about missing patients with pneumonia, not treating them appropriately, lots of guidelines that saying that you need to use a broad spectrum approach and get antibiotics started very quickly. And because of that ambiguity and the fear of doing harm to patients that are missed, I think that this is a ripe area for antibiotic misuse and a place where stewardship can have an impact. So people who present with signs and symptoms of pneumonia are amazingly common. We have about 10 million office visits per year for cough as the chief complaint. Only about 5% of those folks have pneumonia. The way to try to differentiate those patients from folks who have cough for other reasons would be to look for, is the cough productive? Do they have shortness of breath, chest pain, fever? And then non-respiratory complaints as well. So fever, chills, malaise. Oftentimes younger patients, kids will have a fair amount of gastrointestinal overlay with that, so a fair amount of nausea and vomiting, et cetera. And then I would point out that with extremes of age or with immunosuppression, patients can have atypical presentations of their pneumonia. Being a good antimicrobial steward is really just being a good clinician. And that's one of the statements that I've made in courses that we have with our learners at UNMC. And so what I mean by that is that, in order to make good choices of antibiotics, you have to be a careful and thorough and conscientious clinician. You have to take your time. You have to do a good physical exam. You have to take a good history. All those are things that we learn as we, start to take care of patients, and there's really no secret to this. There's just no substitute for taking your time with somebody and being careful and thoughtful and show some critical thinking skills and asking good questions. And so that's one of the things that I would emphasize. This is hard work. It's not simple. It's not somebody can come and whisper the magic word in your ear and then suddenly, you're this wonderful antimicrobial steward. It's really on an individual patient basis, hard work. And there's no substitute for that hard work in making good antibiotic decisions. One of the things that we emphasize as we're teaching our medical students and house officers how to approach the patient with pneumonia is taking a good clinical history. And you want to do that because you can elicit these triggers from the history that will often tell you what is the cause of the pneumonia and get you headed down the right pathway to making a specific etiologic diagnosis. Now, I'm not going to go through all these with you because I don't have time, but there's obviously a huge number of environmental and occupational exposures, a variety of zoonotic exposures, travel, etc. And what I tell my learners is that, if you go into the room and you start asking specific questions on these, your history taking will take you about 2 or 3 hours, and your patients will think that you're a total nutcase. So you don't go in and say, gee, do you like to raise parakeets? And have you, traveled to an exotic location and been exposed to rodent-contaminated urine? You just can't do that. And so you ask a couple of open-ended questions with all of your patient encounters, and it simply is, what do you do for your occupation? What do you like to do for fun? Have you done anything unusual or had any travel or exposures that you can think of? And if you ask people just those 2 or 3 questions, they usually come to you with these sorts of things. They'll say, gosh, I have this mind-numbingly boring job of working as an accountant for an insurance company, and therefore on weekends I have to get on my bicycle, go trudging through the trails and looking for unexplored caves. And so then it's like, oh, okay, well, let's start talking about some exposures here. So that's really the way you want to approach this. And then here's some other underlying etiologies for pneumonia. But again, it's just taking a careful history that will get you on track a lot of times with identifying some of these unusual causes for pneumonia. Then you want to do a careful physical exam. You want to just simply observe your patient and see how they're breathing. Are they breathing fast? Are they cyanotic? You want to listen to them, and all of these signs are predicated upon the fact that consolidated lung transmits sound waves better than aerated lung, and so you start to see some of these abnormalities. And then you subject them to listening, and I found this slide out on the web someplace, and I just put it in there because I thought it was kind of funny. But then, I looked at it, and it's actually an interesting statement on the practice of medicine in yesteryear and the practice of medicine today. So obviously, we don't use these kind of stethoscopes anymore where everybody gets to listen at the same time. But if you can look at this patient, he obviously looks very displeased, and probably nobody asked him if it was okay to take his picture, is going to be my guess. And then you got all these old white guys here, at the front, and this poor woman who's in the back, totally excluded. And what a different view today in medicine, and I would say that's been for the positive. That we take patient rights, obviously, and their privacy very seriously, and obviously we're a much more team-based approach and very inclusive now. I'm also very bullish on examining the sputum, and I think this is kind of a lost art, unfortunately. With all the clinical regulations and CLIA and billing regulations, most people don't examine sputum anymore. They send it off to the lab, and they hope that their lab technicians do a good job with this. I don't know that there will ever be a change in that, quite frankly, but I still think that it's very valuable to send off sputum in appropriate patients and to try to make a specific etiologic diagnosis. So you want to send off a sputum, and the reason for doing that is you want to optimize your antibiotic selection, so you want to make a specific etiologic diagnosis and then be able to offer an antibiotic that really targets that etiology. You want to limit the consequences of inappropriate antibiotics. So obviously, if you're using something overly broad, you'll be able to cone down on it when you know what the pathogen is. And there are values to it from a public health standpoint that if we don't send off sputums, if we're not doing these cultures, how are we going to know what the antibiotic susceptibility pattern is? How are we going to pick up when we have the odd cases that sometimes cluster? So again, there's public health significance to this. And then something that I think is totally unrecognized by most people is that there really is value to a negative sputum culture and a negative sputum exam. So we spend a huge amount of time worrying about patients with MRSA and multi-drug resistant gram-negative organisms. And if you do a good sputum before you start your patients on a bunch of antibiotics and it comes back without the presence of those organisms, you can feel relatively confident that that patient isn't infected with a multi-drug resistant Pseudomonas or an MRSA. Those organisms are generally exceptionally easy to propagate in the laboratory. And so if you don't see them, they're probably not there. And that will allow you, again, to make better choices with your antibiotics. And here's an example of a terrific sputum gram stain. If you saw a patient with this gram stain, you would immediately know that it was pneumococcus. You wouldn't have to worry about any other gram negatives or any other pathogens, and you'd be able to treat that patient appropriately. This is the microbial etiology for community-acquired pneumonia. It really hasn't changed much in a lot of years that have been looked at. Your number one cause of this would be pneumococcus, and then Moraxella and Haemophilus. And then you start to get into smaller pieces of the pie with Staph aureus and some of the anaerobes. And then depending upon what part of the country you're in, you might see very, very different pieces of the pie due to Legionella or the chlamydia or something like that. So again, this hasn't changed a lot over the decades. One thing, however, that does and has been changing more recently is the more we look for respiratory viruses with the ability to do these nested PCR platforms, the more we find that viruses are either the sole pathogen that we see in the lower respiratory tract or a co-pathogen. And I think that's something that we still need to learn a lot more about. One of the things that I did want to chat about more in depth is the use of Procalcitonin as a real tool in antimicrobial stewardship. And so we're going to get into that now in a little bit greater detail. So you already heard me talk about Procalcitonin use for trying to differentiate bronchitis, viral causes of it, and more serious bacterial causes. Obviously, we can use that as well in various other infections, and where it has probably been most greatly studied is in lower respiratory tract infection and in sepsis. Now, Procalcitonin is a peptide that's made largely in the thyroid, under normal circumstances that's then converted into calcitonin and is useful for calcium homeostasis and regulation. And that's shown in this blot, this gel blot, where under normal circumstances you can see that all of your procalcitonin is found in the thyroid and just a little tiny sliver here in lung tissue. Now, under conditions of severe infection, and this is sepsis, but you could put in lower respiratory tract infection as well, you can see that for whatever reasons, procalcitonin is made in a whole host of tissues under stress. Under stress due to infection. And so you can see again, lung, liver, spleen, intestine, fat tissue, lymph tissue, all of these are now making procalcitonin, and it then leaks out into the blood and you can detect it as such. It appears that procalcitonin is triggered by lipopolysaccharide in gram-negative organisms, and it's also upregulated by various pro-inflammatory cytokines that are triggered early in the course of infection. And it appears to be downregulated by interferon, which is what your body makes when it's under assault by viruses. So it's kind of a very interesting biomarker, probably the best one that we have right now. Hopefully there'll be better ones that come in time. But again, it seems to be relatively specific for severe bacterial infections and can be useful in certain situations. This shows procalcitonin production over time. And so the red line shows procalcitonin. It generally goes up in the first about 6 to 12 hours of an infection. Shortly after, you get these pro-inflammatory cytokines that are secreted first. And then it typically has a fairly short half-life, about 24 hours, and starts to come down. You can see that it does go up more quickly than your C-reactive protein or your other inflammatory markers. There are a few things that kind of throw it off. So it is elevated when you have a patient in chronic renal failure or in stage 4 congestive heart failure. But in the studies that have looked at it, it has a specificity of about almost 90% in lower respiratory tract infections and a sensitivity of 94%. So again, not a perfect biomarker, but pretty good, and really does help you in a lot of patients make a better decision as to whether they're infected with bacteria and whether you should start antibiotics. And now I want to get into just a little bit more data to help convince you and make you feel more confident in the use of procalcitonin as a test. The next series of slides are going to come from, I think, a fairly well-done meta-analysis that looked at the use of procalcitonin in treating patients with lower respiratory tract infection. And so there were, 11 papers that were included in this meta-analysis looking at thousands of patients. And what you can see in this forest plot is that if you use procalcitonin in making this decision of whether you should start antibiotics, that there was a significant decrease in antibiotic administration. So again, when you use this as a tool, it really can result in you feeling confident enough to not starting antibiotics in a very large number of patients. So here you can see the odds ratio was 0.26, meaning that there was about 75% decrease. And then if the same meta-analysis, looking at the use of procalcitonin in the total antibiotic use, there was a mean difference of a little over 2 days in the patients that were managed with procalcitonin as a tool versus the control patients, which were just largely left to clinician decisions. So again, a real benefit in the number of days of antibiotic use. Now, furthermore, you can see that in the same meta-analysis, it didn't really impact upon the length of hospital stay, and there didn't seem to be much impact on mortality. So you can look at this different ways. You can say, well, gee, it doesn't really impact these outcomes that are so important. But you can also look at it and say, well, really the way you should be thinking about this is that you're not doing any harm to your patient. You're not missing people. They're not staying in the hospital longer, and they're not dying more. Because we're using this and then missing patients and having bad things happen to them. So the outcomes are better with regard to antibiotic use, and they're no different with regard to some of these other markers of outcome. So again, should give you a fair amount of confidence in the use of this tool, that I'm not hurting people and it's helping me to make better antibiotic decisions. Now here's another meta-analysis that rather than looking at overall study data, they actually coned down on patient-specific data. These were in 26 different trials from 12 different countries. They showed that mortality was significantly lower in the procalcitonin treated patients, so this was even more supportive of the use of this tool, and that it was associated with about the same amount of decrease of antibiotic use that we saw in the previous meta-analysis, and that it was associated with a significant reduction in antibiotic-related side effects. So this is, again, all very, very strongly supportive information that you're actually helping some of those outcomes that are so important with regard to mortality or length of stay, and you're decreasing your antibiotic-associated side effects. And then you can see in this figure that was taken from the paper, the daily amount of antibiotic patients that were on antibiotics in the control group, shown by these sort of pink bars, versus the blue bars where they're in the procalcitonin group. And then the overall antibiotic use was about what we saw in the previous paper, with a couple days difference in overall antibiotic use. So again, very strongly supportive information. And then if you're looking for how to put this all together, we have some advice on the Nebraska Medicine Antimicrobial Stewardship website. Here's the address for you. And what we're recommending to clinicians is that they check their procalcitonin, and if it's less than 0.25, we're suggesting that you really need to consider whether antibiotics are in the best interest of your patient. If you're really concerned about it, go ahead and start the antibiotics, but you may want to recheck a procalcitonin fairly quickly thereafter. If it's still down, it should again trigger, okay, I probably don't need to have this person on antibiotics. If it's above 0.25, you can see that we encourage the use of antibiotics in those patients. So again, I think a pretty useful tool for you in evaluating your folks with lower respiratory tract disease. Okay, so next question we want to talk about is how long should we be treating these patients after we've used procalcitonin maybe to make that decision. We think they have pneumonia, they're on antibiotics. How long do they need to be treated? So what do the guidelines say? Well, there's a bunch of different advice out there. Older guidelines from the IDSA and the American Thoracic Society suggest that 5 days is appropriate. The European Society suggests less than or equal to 8 days. The UK suggests that 5 days is appropriate for people with low severity and that they're responding to treatment, and that maybe 7 to 10 days for people who are more severely ill. And then in the most recent IDSA guideline on hospital-acquired pneumonia, it suggested that 7 days can be used. So relatively short courses of antibiotics are appropriate. Okay, this is very, very different than a few years ago where everybody who had pneumonia got treated with 2 weeks, sometimes longer. Now we're talking 5 days or 7 days is appropriate for an awful lot of our patients. And this is another place where you can use procalcitonin as a test. And when your procalcitonin has decreased by 80 to 90% of the peak is oftentimes a pretty strong signal that your patient has finished the beneficial course of antibiotics and that you can stop those antibiotics. Okay, what about de-escalation in the treatment of pneumonia? This is a place that we talked a little bit about this in Dr. Srinivasan's talk about doing an antibiotic timeout or how do you appropriately de-escalate your therapy. This is a place where I think we can still do a lot of work. Okay, so it's hard to do these studies. The data is still sort of soft in certain respects. So I think those of you who are out there and thinking about how to take care of patients better and asking those questions, this is a place where you can get involved and do a little bit better. So this is from a systematic review, 9 observational studies, de-escalation of empiric antibiotics, based upon when you get culture results done, and using the grade formula, which is kind of a rigorous way of evaluating the rigor of the data, suggests that the data is of low quality to very low quality. Didn't show a whole lot of improvement in some of the outcomes that we look at, but did show a statistically significant difference in hospital stay with a significantly decreased number of days in the hospital when you're using the de-escalation sort of pathways. So again, I think we can do some more work in here, but what we have is supportive. Another tip that I would give you in looking at these patients and potentially de-escalating is using your MRSA screening data if you have it. So there are a fair number of hospitals that, screen for MRSA carriage when a patient comes into the hospital. If they then develop pneumonia during their hospitalization and they had an MRSA screening test that was negative, the negative predictive value of that test is about 94%, telling you that the risk of MRSA pneumonia in that patient is very low, and you don't have to put that patient on vanc or linezolid when they develop their hospital-acquired pneumonia. So again, one more tip for you as you're looking at these patients and trying to figure out, do they need to be on vanc or linezolid when they develop a pneumonia while in the hospital. One of the last things I want to talk about is getting rid of this term healthcare-associated pneumonia. I think this is something that has really led us astray. It was well-meaning when it first came out, but has led us astray and has really encouraged the overuse of antibiotics. And so let's explore that just a little bit. So this is a paper that I thought, I love the title on it. Is there any reason to continue to utilize this label in the 2019? I'd advise you to go take a look at this. But the issues that were identified is that this terminology was first sort of promulgated back in 2005 with the IDSA, American Thoracic Society guideline. And they defined healthcare associated as anybody who develops a pneumonia that had a previous hospitalization for 2 days in the last 3 months, lived in a nursing home, had home infusion therapy of any type, was on dialysis, had wound care, or had a family member with a multi-drug resistant organism. Huge population, right? When you think about who comes into the hospital, a lot of folks coming in from long-term care, a lot of people coming in from dialysis units, et cetera. And so this really prompted folks to use this broad spectrum approach to antibiotics. So everybody who came in got labeled as having healthcare-associated pneumonia, a garbage term, and then got put on 2 or 3 different antibiotics. What we have learned more recently, and again, this was well-meaning when it first came out because there was the thought that, these people really did have multi-drug resistant organisms and you really did need to treat them with a broader spectrum antibiotic approach. So what we have found in more recent years is that it way overclassifies patients as having multi-drug resistant organisms. Here's data from our own organization where we found that about 95% of the time patients with that label of healthcare-associated pneumonia did not have a multi-drug resistant gram-negative organism or MRSA. And so we were 95% of the time over-prescribing antibiotics. Here's additional data to suggest the same thing, that the mortality associated with healthcare-associated pneumonia is all driven by their underlying morbidities, not by multi-drug resistance. Here's some stuff that said there was no survival advantage to using that definition. And then here's one actually showing excess mortality in patients who were compliant with the HCAP guidelines rather than having clinicians treat them as they thought was more appropriate. So again, lots of reasons for getting rid of that terminology. So the more recent recommendations for treatment of hospital-acquired pneumonia or ventilator-associated pneumonia are shown here, where you want to suspect patients as having a multi-drug resistant organisms when they've been hospitalized for 5 days or longer, when they've had prior IV antibiotics, so not oral antibiotics, but IV antibiotics in the past 90 days, they're dialysis, or they're just simply so sick that you just can't miss. So, that's a clinical decision that you have to make. And then when you see these patients, you want to use combination of an anti-pseudomonal beta-lactam along with vancomycin or linezolid. If your resistance rate within your community, which we'll know in Nebraska because as Dr. Tierney related, we're going to have, various sorts of antibiograms. When your resistance rate is high, greater than 10%, you might want to use 2 gram-negative agents. So this is a real change in our terminology and our thought process on who has a multi-drug resistant organism and using antibiotics more wisely. There unfortunately continue to be a lot of barriers to antimicrobial stewardship in our hospitals. This was kind of a recent and interesting paper that identified some of these, and I think we still have some room to work on these. So within lower respiratory tract infections specifically, we have a huge amount still of diagnostic ambiguity. So, we still don't know in many, many cases of what is that patient infected with. This fuels people's fear and their overuse of antibiotics. So those of you who are working in clinical microbiology labs, help us out, get these new diagnostic tests tested and develop new ones for us so that we can apply these at the bedside and try to make more specific diagnoses. So we continue to have a lot of diagnostic ambiguity with regard to, do they have pneumonia versus bronchitis? Is it viral? Or is it something else that's totally non-infectious? And something I haven't talked about at all is, do they have colonization versus infection? Again, you can use your MRSA test a little bit for that, but there's still lots of other organisms that people could be colonized by and not have infections. There's an underappreciation of the detrimental effects of inappropriate antibiotic use. Again, Dr. Srinivasan mentioned in his talk that, just talking about the fact that you're going to get a resistant pathogen and all of us are going to die from that in the future doesn't resonate with people. They're wanting to worry about that specific patient. And so again, I think we still have room to work with our public education, trying to get people to really understand the detrimental effects of antibiotics. There's a lack of trust sometimes in our guidelines, and sometimes we have role models and hierarchy that work against us. I'll end with, we need to all do a better job in preventing pneumonia in the first place. So get your patients to stop smoking, use appropriate vaccination for flu and for pneumococci in those patients that need it. And my final words are, don't treat upper respiratory infections with antibiotics. Don't treat acute bronchitis with antibiotics. Carefully select patients with exacerbation of chronic bronchitis and base your treatment decisions on your Procalcitonin. When encountering a patient with a suspected pneumonia, be a good clinician and make a specific diagnosis. Use your Procalcitonin to assist in determining whether that patient's infected with a bacteria. Treat your patients with pneumonia for the shortest period that you can, and abandon the term HCAP in your terminology. And thank you very much.